Welcome to the Ask the Expert webinars brought to you by the Wiley Knowledge Hub on Atherosclerotic Cardiovascular Disease and Lipidology, supported by Novartis. The Knowledge Hub is an educational resource intended to provide healthcare practitioners with all the latest research and clinical updates in ASCVD and lipidology, enabling HCPs to optimize patient care in clinical practice. Our distinguished speaker for today's webinar is Professor Lale Tokyozoglu. She is a professor of cardiology at the Hacettepe University and the immediate past president of the European Atherosclerosis Society. In today's presentation, Professor Tokyozoglu will focus on the treatment and management of ASCVD and dyslipidemia in female patients. We request you to send your questions through the chat box and respond to the polls that will be presented to you during this webinar. At the end of the talk, we'll present your questions to our speaker.
Hello, my topic today is dyslipidemia and atherosclerotic vascular disease in women. I'm Lale Tokyozoglu from Hacettepe University, the immediate past president of the European Atherosclerosis Society. Atherosclerotic vascular disease is the leading cause of mortality in most parts of the world, more so in middle-income countries and in women. Here you see the European cardiovascular disease statistics showing that almost half of all deaths in women in Europe are due to cardiovascular disease. The disease usually manifests itself later in life in women, but unfortunately, cardiovascular disease is increasing in younger women due to increase in cardiometabolic risk factors. Risk factors are the same in men and women, but we tend to see obesity, diabetes, sedentary lifestyles, psychosocial stress, and inflammatory diseases more frequently in women, and women are physically more inactive than men. The Global Burden of Disease study has demonstrated that in women, the number one risk factor attributable to death is high systolic blood pressure, whereas in men, it's still tobacco. The same study revealed that high blood pressure is by far the most important contributor to age-standardized cardiovascular mortality in women, followed by high LDL cholesterol, high fasting plasma glucose, and a high body mass index. Some risk factors may have a stronger impact on women. Smoking, diabetes, psychosocial stress, and dyslipidemia has been shown to impact women more in some studies. The InterHeart study found that dyslipidemia was more powerfully associated with myocardial infarction in women than in men. Obesity is also seen more commonly in women, especially in middle-income countries. The Framingham Heart Study showed that the excess risk of cardiovascular disease that could be attributed to obesity was much higher in women than in men, and a similar increase in body mass index was associated with a greater increase in systolic blood pressure, both in men and in women. Age-related increases in abdominal obesity also affect the lipid profile non-favorably, even if the female is not obese and healthy. Every time the visceral abdominal adipose tissues increases, there also occurs some unfavorable effects in the blood lipid profile that is atherogenic. Diabetes is also thought to have a stronger impact on women. As you can see here, an analysis from the UK Biobank found a higher risk of myocardial infarction associated with diabetes in women than in men. and each 1% higher hemoglobin A1C was associated with an 18% greater risk of MI in both women and in men. The WISE study also demonstrated the importance of metabolic status. Here you see cardiovascular event-free survival by metabolic status, and patients with metabolic syndrome tend to do worse than metabolically healthy controls. Smoking has a strong impact on women. In general, men smoke more than women, but young women are increasingly taking up smoking. A large meta-analysis found that the increased risk of cardiovascular disease associated with smoking was 25% higher in women than in men. Although this was not confirmed by the InterHeart study, more data are needed on this topic. The population attributable risk for lifestyle factors is significantly higher in women. We know that mental stress and depression are seen more frequently in women, and this has been related to the presence of metabolic syndrome. There is greater loss of physical function in women, leading to risk factor clustering, and therefore lifestyle confers greater protection in women than in men. In addition to the well-established risk factors we have been talking about, there are also under-recognized risk factors, such as psychosocial stress, abuse and intimate partner violence, socioeconomic deprivation, poor health literacy, and environmental risk factors. Also, sex-specific risk factors are increasingly becoming recognized. In younger women, polycystic ovary, oral contraceptive use, early menopause, or primary ovarian insufficiency may increase the cardiovascular risk. Pregnancy-related problems such as gestational diabetes, hypertension, and preeclampsia is also a risk modifier. And in older women, menopause and hormone replacement therapy are risk modifiers. In the most recent 2021 European Prevention Guidelines, these sex-specific conditions have been highlighted as risk modifiers. So in the guideline, a history of preeclampsia, pregnancy-induced hypertension or diabetes, polycystic ovary syndrome, and a history of premature or stillbirth are all considered risk modifiers and should be taken into consideration when calculating the risk in a female. Recently, in the European Heart Journal, a cardiovascular health in women consensus paper has been published. This consensus paper highlights the importance of female-specific risk factors and recommends some strategies to address this excess cardiovascular risk in women. Early detection and lifestyle modification are recommended as ways to combat this risk. Inflammation is also seen disproportionately in women because they're affected more by autoimmune disorders. And the chronic inflammation caused by autoimmune disease is associated both with endothelial dysfunction and acceleration of atherosclerotic disease. These females also use steroid therapy, which may aggravate the cardiometabolic risk. So the presence of systemic inflammatory disorders should be considered as a risk modifier as well. Throughout life, women undergo hormonal changes, and estrogen has both pro and anti-atherogenic effects. It affects the function of endothelial cells, macrophages, dendritic cells, and smooth muscle cells. Early in life, it improves endothelial function, increasing endothelial relaxation, decreasing the permeability of the endothelium, and decrease proliferation of some of these cells. The disease manifests later due to all these protective effects of estrogen. But later on in life, it starts to exert its unfavorable effects, increasing inflammation and increasing thrombosis as well. There are negative effects of aging, which become manifest after menopause. Usually, in most women after menopause, the visceral obesity is increased, as well as glucose intolerance. Lipids are affected unfavorably. The blood pressure is increased. There is endothelial dysfunction, depression, and insomnia, which all contribute to atherosclerosis. Unfortunately, replacing the hormones is not the solution. The HERS trial showed us effects of hormone replacement therapy in secondary prevention. And as you can see here, coronary heart disease, myocardial infarction, and death were not decreased with hormone replacement, and venous thromboembolism was increased. In secondary prevention, the Women's Health Initiative looked at the effects of hormone replacement and also showed no favorable effects with hormone replacement therapy. So when we look at the risks for hormone replacement therapy, we see that they can increase endometrial cancer, breast cancer, stroke, and venous thromboembolism risk. For this reason, hormone replacement therapy is not recommended in women at high cardiovascular risk and after a previous cardiovascular event. It may be used with caution within 10 years of menopause or below 60 years of age if the female is severely symptomatic and the risk needs to be weighed against the benefit. Looking at the anatomy, women usually have smaller coronary size on CT, independent of the body mass index or left ventricular hypertrophy. The small coronary size and a high myocardial blood flow all lead to high shear stress, which may delay the progression of atherosclerotic vascular disease. In men, the atherosclerotic plaques have a larger lipid core, more calcification, thicker fibrous cap. So this reflects to a higher calcium score and more obstructive coronary artery disease in men. In women, the plaques usually have less lipid core, less volume, less calcification, so women tend to have a lower calcium score and less obstructive atherosclerotic coronary artery disease. Here you see the results of the MESA study looking at 10-year association of coronary artery calcium with cardiovascular events. And in both genders, if the calcium score is below 100, the risk is relatively high, relatively low. But if you go above 100, the risk increases significantly, more so in women. These findings were confirmed in the calcium score consortium in more than 60,000 patients with a follow-up of 12 years, showing that the calcium score predicts mortality better in women compared to men and should be used as a risk modifier. Dyslipidemia is a very important risk factor in women and should be managed properly. To address lipids, we need to determine the risk of the patient first, because we become more aggressive as the risk increases. We know that those with the highest cardiovascular risk will benefit most from LDL cholesterol reduction. In Europe, we use the SCORE2 system to determine the risk, and in the US, the pooled cohort equation is used. So in most healthy people, we need to use this risk stratification system to determine the risk of the female. However, if a patient already has atherosclerotic vascular disease, chronic kidney disease, diabetes, or one markedly elevated risk factor, let's say the LDL is above 190 milligrams per deciliter, then they will be automatically at high or very high risk. Therefore, the scoring table is then not necessary. The risk estimation charts that we use, unfortunately, may underestimate the risk, especially in younger women, because a low absolute risk in a younger woman may conceal a high relative risk. To overcome this, we may use the relative risk charts or take into account risk modifiers and imaging studies. We know that cumulative exposure to LDL cholesterol increases the plaque burden and the cardiovascular risk. For example, if a female has familial hypercholesterolemia, then the accumulation of LDL will start much earlier in life, and age at which risk of MI begins to rise is much earlier compared to a person who acquired high LDL cholesterol. So it's important to determine if a female has familial hypercholesterolemia or not. Here in Europe, to rule out FH in women, we use the Dutch Lipid Clinic Network diagnostic criteria. By asking a few questions and looking at a few clinical parameters, we can determine whether the patient is likely to have familial hypercholesterolemia. Family history, clinical history of an early cardiovascular disease, seeing xanthoma or arcus cornealis before age 45 years, and having high LDL cholesterol levels are all important parameters to help us rule out the disease. And for final diagnosis, we can do a DNA analysis. And if a female has familial hypercholesterolemia, we need to be more aggressive in treatment. The treatment targets and goals for cardiovascular disease prevention are identical in males and females. So we need to tackle all the risk factors that we know equally. The recent European prevention guidelines take a personalized approach to risk factor modification. In apparently healthy persons, after lifestyle recommendations, age and the SCORE2 risk are used to determine how aggressive we need to be with blood pressure lowering and LDL cholesterol lowering. The ultimate treatment goals across risk categories are identical in men and women. For those with high and very high risk, at least a 50% reduction of LDL from baseline is necessary. The goal is less than 55 milligrams per deciliter in very high-risk women and less than 70 milligrams per deciliter in high-risk women. And for moderate risk, we try to keep LDL below 100 milligrams per deciliter. The US multi-society guidelines were published in 2018. And although they take a slightly different approach, the main recommendations are very similar. If a female has LDL above 190, has diabetes or high risk, then usually statins are recommended to get to LDL cholesterol goal. So overall, statins are recommended to get to LDL goal in high-risk primary prevention and all secondary prevention patients with the same indications in men if lifestyle recommendations are not adequate. However, lipid-lowering therapy should not be given during pregnancy and breastfeeding. And during pregnancy and breastfeeding, if the patient has severe familial hypercholesterolemia, bile acid sequestrants and apheresis may be considered. The views on this are changing slightly. There is a very recent publication looking at neonatal outcomes among women using statins for more than 3 months prior to pregnancy and maintaining use during pregnancy. And you see that the outcomes are not as unfavorable as we thought previously. For this reason, FDA has recently requested removal of strongest warning against using statins during pregnancy. However, we have to be extremely cautious and not and use this as maybe a last resort in very high risk familial hypercholesterolemia females if we have exhausted all other options. What about aspirin use in women? In secondary prevention, it should be used with similar indications to men. So all secondary prevention, unless indicated otherwise with high bleeding risk, should use it. But we do not recommend it for primary prevention in healthy women with no major risk factors. And we do not recommend using routinely after the age of 70 years, especially if the female has a prior bleeding risk. In primary prevention, we may recommend it for current smokers, for those with a high calcium score or a high family history or uncontrolled risk factors. Of course, we need to take into account the risk of bleeding as well. We should take into account also that the response to therapy in women may be different, and this may manifest itself in drug interactions and side effects. Women tend to have a lower body weight, higher proportion of fat, different endogenous hormone levels, and there may be differences in enzyme activities involved in drug metabolism. They may also have a lower glomerular filtration rate, especially as they age. Attaining treatment targets in coronary artery disease patients is very difficult in both genders. Here you see the EURA-ASPIRE study we conducted in 24 European countries. And you see that blood pressure, LDL cholesterol, and diabetes goals are usually not reached in all these patients. But you also see that females are less likely to get to goal. There are several different reasons for this, but dyslipidemia in women is usually undertreated. One recent study showed that female patients are less likely to be offered a statin, more likely to decline a statin or discontinue a statin for LDL lowering. Another study in females with early atherosclerotic vascular disease showed that antiplatelet use, statin use, and statin adherence was worse for women compared to men. In general, women have a greater symptom burden when they have atherosclerotic vascular disease and higher rate of functional disability. But when you look at the angiograms, they are less likely to have obstructive coronary artery disease. But when they do have obstructive disease, they have more adverse outcomes. Also, female patients usually seek attention later. They're underdiagnosed and undertreated. When you look at the angiograms, there's less obstructive coronary artery disease in women, but ischemia without obstruction due to microvascular dysfunction or vasospastic angina can be seen more frequently in women. And these conditions are happening in the presence of classical risk factors or hypoestrogenemia and inflammatory milieu, mental stress, and depression. And the way to treat it is by combating the classical risk factors. When a female has INOCA, the coronary angiogram may be normal, like here. But when you look closely in intravascular ultrasound, you may find some signs of atherosclerosis. And the diagnosis can be made by sophisticated methods such as FFR, positron emission tomography, or MRI. What about acute coronary syndromes? We know that they occur due to plaque rupture or plaque erosion. Plaque erosion is seen more frequently in women than in men. And if the female is a smoker, she is more likely to have erosion. But if she's hypercholesterolemic, more likely to have plaque rupture. Non-traditional risk factors are more common in women, and emotional stress more frequently a trigger for acute coronary syndromes. Women present with atypical symptoms such as dyspnea, anxiety, and they usually have smaller vessels. In men, traditional risk factors are more common. There is usually a physical trigger for the acute coronary syndrome. The symptoms are more typical. They usually have chest pain. They usually access care faster, and usually on angiogram, they have higher plaque burden. Myocardial infarction with normal coronary arteries is also seen more frequently in females, and this may be caused by plaque fissure, microvascular or epicardial spasm, myocarditis, Takotsubo syndrome, or coronary embolism. Earlier studies looking at acute coronary syndromes in women really revealed that women get less evidence-based therapy and have worse prognosis, especially if they have an ST elevation myocardial infarction. They were less likely to receive pharmacological therapy or revascularization. After years of major efforts, educational campaigns, things are slightly better, but women still have worse prognosis after an ST elevation myocardial infarction, seen in this meta-analysis. But this is now mostly due to later age at presentation, comorbidities, although some undertreatment is still present. There have been major efforts since the year 2000, the Go Red campaigns, educational campaigns, advocacies, papers, trying to improve the cardiovascular health of women. The most recent effort is the Lancet Women and Cardiovascular Disease Commission. So this is a paper aiming to reduce the global burden by 2030. Overall, this paper summarizes that women are understudied, underdiagnosed, undertreated, and underrepresented in trials, and that sex-specific mechanisms in pathophysiology are still not well understood. The age-adjusted prevalence in women, as well as myocardial infarction and cardiovascular mortality, are increasing in young women. And the most important risk factors, as I mentioned before, are hypertension, dyslipidemia, diabetes, whereas psychosocial and socioeconomic factors should not be neglected. So I'd like to conclude it by a few take-home messages. The early identification and modification of risk factors is important to prevent atherosclerotic vascular disease in women. Although the disease biology is the same, unique aspects pertaining to women should be considered. And despite substantial progress, underdiagnosis and undertreatment is still a problem. Maintaining a healthy lifestyle and getting to guideline recommended goals for risk factors is important to preserve the cardiovascular health of women. I'd like to thank you for your attention, and I'll be happy to take any questions you may have.
Thank you, Professor Tokyozoglu, for that wonderful presentation. We'll now move on to the question and answer section, and we have a few questions here from our audience today. To the audience, please keep sending your questions through the chat box and do respond to the poll link that we have on the site. So Lale, the first question that we have here for you is, what should you advise to an apparently healthy woman who's entering menopause? How do they go about preserving their cardiovascular health?
Thank you for this question. Now, first of all, since we can expect an increase in cardiometabolic risk factors over time, we need to prepare well for the years to come ahead. Imaging studies have shown us that there is subclinical atherosclerosis present in about half the women in middle age, starting from the femoral arteries and then going up. And we have to make sure that those plaques are not going to get bigger and lead to cardiovascular events. So if the patient has not already stopped smoking, the first thing we need to do is make sure that now is the time to stop smoking. We also need to make sure that the woman knows all her risk factors. And if there are any, they need to be treated according to the guideline recommended goals. Blood pressure control, cholesterol control, as well as diabetes control are extremely important in these females. In addition, lifestyle changes are required. Sedentary lifestyle really hits the women even more than men. So now is the time, if they're not already doing so, is to increase the physical activity. And a healthy diet, which is also important for all ages, should be recommended. So if we're able to implement all these lifestyle changes, as well as control of risk factors, then we can guarantee a better future, because we know that risk factor control in midlife not only affects cardiovascular events later on in life, but also cognitive function, as we're seeing in newer studies. So it's really important to get to guideline recommended goals.
Thank you very much, which kind of segues, I guess, into the next question that we've got. Some women say they don't want to quit smoking because they'll gain weight if they quit. Now, how do you address that question?
We get that a lot from our patients. So the first thing we need to say is it's not guaranteed that you're going to gain weight. And if you watch your diet and exercise, you can stop smoking and not gain weight. But even if you do, the most important part is, and there has been a study on this published in the past few years, even if you do gain weight, your cardiovascular risk will not increase as much as when you continue smoking. So we should do our best to convince the patient to stop smoking.
Okay, thank you. The next question that I have here in front of me is, what are the drug choices for women who are age 45 years, have type 2 diabetes mellitus with hypercholesterolemia?
First of all, when we want to treat hypercholesterolemia, the first thing we need to do is determine the risk of the patient. For a diabetic, we look at the presence of target organ damage, additional risk factors, and also whether the diabetes has been going on for more than 20 years. So if all these are present, the patient will be at very high risk. So the LDL goal will be less than 55 milligrams per deciliter. And if the patient is only at high risk, our goal is 70 milligrams per deciliter. For every patient, we need to start with, for every apparently healthy patient, we need to start with lifestyle recommendations first. And they may get your LDL cholesterol down 10 to 20%. And if they are not adequate, statins will be the first choice. Now, you may say this is a relatively young female, and statins may increase dysglycemia slightly. So are we really sure going to insist on statins? But we know from studies that the protection, cardiovascular protection conferred by LDL lowering is much higher than the slightly increased dysglycemia risk. So for sure, we need to start with a statin and combination therapy if the statin is not getting us to goal. And we have several options for this, starting with ezetimibe, even PCSK9 inhibitors if the patient is at very high risk, and bempedoic acid, which is a newcomer. And we know that it does not increase your dysglycemia risk in the recent studies published. But I would still start with a statin first, unless there is a contraindication for it.
Thank you. We have a question related to COVID. So in the context, do you have an experience related to COVID-19 infection that has triggered cardiovascular events in women out of myocarditis and rhythm disorders?
Yes, certainly. We've seen several patients of both sexes post-COVID who had myocarditis, which was clinical or subclinical, pericardial effusions, and rhythm disorders. We also have seen patients with post-COVID syndrome, which seems to be slightly more frequent in women than in men. We are all learning, trying to tackle how to cope with those. And we're learning every day with new publications coming up. There is no specific publication that I know of which says that COVID causes more myocarditis or pericarditis in women than in men. We know that it causes it more frequently in younger patients. Gender-wise, I'm not aware of a large analysis. But yes, certainly we've had COVID trigger all these events.
Thank you.
Also, during COVID, women were more likely to wait a long time before coming to the hospital compared to men. We have seen it in an analysis done in our country as well.
Thank you. I think I'll move on to the next question, and I hope that has answered our audience what the person wanted to know. Does endometriosis increase cardiovascular risk?
In the European prevention guidelines, it is not specifically listed as a risk enhancer, but there are studies showing that endometriosis does increase cardiovascular risk. And this has been mentioned in the Lancet Commission's paper as well. So the answer is yes.
Thank you. We've got a couple of more questions that have come in. What is the prognosis of non-obstructive CAD?
We weren't well informed about non-obstructive CAD too much because in angiograms, we couldn't really see the extent. But now that we're doing CT angiograms, we're seeing them more clearly, the presence of plaque and the quantity of plaque a person has. The CONFIRM study was an important CT study showing that people and women with non-obstructive coronary artery disease, the prognosis was not as good as those with normal coronary arteries and not as bad as those with obstructive coronary artery disease. So we can say that it will increase your cardiovascular risk significantly because even if you have non-obstructive plaques, some of them may be vulnerable and may rupture or erode, leading to acute coronary syndromes. So these patients should also be managed aggressively with risk factor control.
All right, so we'll move on to the last question that I have here. How do we handle a woman not wanting to take statins because of myalgia?
Yes, statin adherence, unfortunately, is less in women compared to men. Now, we know today that most of the myalgias claimed to be caused by statins are due to other causes, and statin reluctance is more frequent than statin intolerance. So we will try to make sure that the myalgia is due to the statin and not any other cause. Women who are hypothyroid, have other existing diseases, vitamin D deficiency, are more likely to get myalgia on a statin than others. We can also look at the CK level, and if it's elevated more than 4 times upper limit of normal, that is also an important criteria, but we do not have specific criteria to diagnose, so we have to go clinically. If we are sure that the myalgia is due to a statin, we can change the statin or switch to a lower dose. And if there are CK elevations, we can do a statin washout first before changing to a different statin or to a lower dose of the same statin. But if these are not adequate, then we can also think about other medications such as ezetimibe, bempedoic acid, or PCSK9 inhibitors, solo or in combination with a statin. How aggressive we need to be will depend on how high risk the patient is, because the higher risk the patient is, the more we have to push to try to get to goal.
Thank you. We just have one question coming in. What are the subclinical ACS? How would you diagnose them?
Subclinical atherosclerosis and subclinical acute coronary syndrome are two different entities. So let me start with subclinical atherosclerosis. Subclinical atherosclerosis is when the patient is feeling perfectly healthy, but you do a carotid ultrasound and you see a small plaque, or you see the plaque on the abdominal ultrasound, or you see the plaque on CT in the coronary angiogram, or you have a high calcium score on CT angiography. So you're not going to see this unless you look for it. The patient will be completely asymptomatic because the lumen obstruction will not be more than 50% yet. But this is a good time to start our preventive efforts so that the plaque does not grow. For acute coronary syndromes, they are less likely to be subclinical, because even if the patient is not experiencing chest pain, women and elderly patients may not feel the typical chest pain. Instead, they will feel dizzy, short of breath, nauseated, or even present with syncope. But we can make the diagnosis by biomarkers like troponin, as well as some help of the ECG. But I think both entities are important, but of course, acute coronary syndrome is an emergency.
Thank you, Lale. I think we don't have any further questions from the audience. So on behalf of the team at the Wiley Knowledge Hub, I'd like to thank you very much for this insightful presentation and for taking all our audience questions. And obviously, thank you to everyone who's attending this talk and for sending in your questions. We look forward to meeting all of you again on March 17th, when we present a talk by Professor Deepak Bhatt on the REDUCE-IT trials. Professor Deepak Bhatt is the Executive Director of the Interventional Cardiovascular Programs at Brigham and Women's Hospital, and also the Principal Investigator of the REDUCE-IT trials. The recordings of today's webcast will be available shortly on the Wiley ASCVD and Lipidology Knowledge Hub to view these and any other relevant resources. Once again, Professor Tokyozoglu, thank you very much for the talk, and thank you all of you for your participation.
Thank you.